Hi, in this discussion, we'll be talking about your spinal disorders. Particularly, our focus is your spinal cord injury. To begin with, when I say spinal cord injury, so it is an injury to the spinal cord or the vertebral column. So they call that the vertebral column is the one that supports our spinal cord. Okay, so this may support our soft tissue or intervertebral disc. Okay, and this spinal cord injury is usually caused by trauma. So if you would look at the anatomy here, this is your spinal cord and this is your vertebral column, also known as your spinal column. So the bone that protects our spinal cord is again referred to as your spinal column. So your spinal cord injury may result due to the compression caused about by the injury in your spinal column. There are different mechanisms for the injury in your spinal cord or your spinal column. To start, one is your forced flexion or hyperflexion. So, as the term implies, so you have flexion. So, as you can see, there is a bending of the neck towards the front or the anterior aspect, since we are talking about flexion, the opposite of which is extension. Now, when I say forced flexion or hyperflexion, there is forcible forward bending. And this forcible forward bending would lead to the compression, okay, of your vertebral body on the anterior aspect, okay, and would result to the disruption of your ligaments and intervertebral disc. The next type of injury is your forced extension or hyperextension. So when I say extension, so meaning your neck is bent backwards, so this force extension or hyperextension injuries would refer to forcible backward movement of your spine. Okay, that would lead to the bending of your ligaments and would also cause your vertebral fracture. So as you can see, if the force is geared backwards, the vertebrae tends to be displaced, okay, along with the intervertebral disc. And what happens on the posterior aspect is that there will be ligament compression, and then there will also be spinal cord compression. So either way, okay, there will be compression. However, the part of the spinal cord that will be affected would vary. So if you can notice in a force extension or hyperextension, it is this aspect or the posterior aspect of the spinal cord that will be affected. Now, another this is a comparison of your hyperextension surgery and your hyperflexion injury, I mean, not surgery. So if you can notice in hyperextension, the compression is brought about backwards. And here you can see that the intervertebral disc are either torn down. But here on the aspect of your hyperflexion, it is the intervertebral ligaments that are torn down. But what happens into your intervertebral disc is that it is compressed. Okay, in either way, the tube is compressed. The spinal cord, which is the tube inside your spinal column, is compressed. Then, you also have your vertical compression or axial loading. So in your vertical compression or axial loading, what happened is that there is a vertical load. Let's say, for example, there's something hard or heavy that will drop on the patient's head that would result to vertical compression or axial loading. So the application of your vertical force to the vertebral column would result to the vertebral shatter or burst. Okay, still you will have your fracture and then there will be compression of your intervertebral disc. Okay, resulting still to the pain and then the other manifestations related to the compression of your spinal cord. Then you also have excessive rotation. So what happens in excessive rotation is that the head is excessively turned, which would result to twisting of the head and the neck or extreme lateral flexion. And this may result to tearing of your ligaments, still fracture, or still compression. So this may occur if your patient had an accident or your patient is on a rotatory machine. Okay, so the tendency is for your patient to have excessive rotation. This slide is another illustration of how your hyperextension and hyperflexion would occur. So as you can notice here on the right, on hyperflexion, there is an overstretching of the ligament, which would lead to the pain manifestation and then the disabling effect on the part of the patient. Whereas here on the hyperextension, as you can see on the lower left side of the slide, okay, what can be seen is that there is a problem on the intervertebral disc. Okay, and possibly the anterior longitudinal ligament. So this may cause persistent neck, scapular, and shoulder pain, which would necessitate disc removal and later on interbody fusion. Okay, so the two differences or the areas injured because of either anterior or I mean hyperflexion or hyperextension. Now, deformation. When I say deformation, it is the alteration of the spinal cord and soft tissues which can be caused by abnormal movements. So most often this occurs in your cervical and lumbar regions. So, when I talk about spinal cord injury class, basically this is talking about injury to the spinal cord itself, and the signs and symptoms would vary depending on the part of the cord which is compressed or affected. However, the most common and frequent sites now, for spinal cord injury are your C1, C2, then you have your C5 to C7, and then you have T12 and L1. Okay, although the entire part of the spine is as equally as important, so it's most common to occur in these sites of the spine. Now, this results to damage to the vertebra and ligaments, unstable spinal column compression, or stretching of the cord. Let's talk about the pathophysiology of this condition. So what happens in spinal cord injury is that after a primary injury, microscopic hemorrhages in the gray matter of the cord is expected. And there will also some bleeding into the subarachnoid space. Now, because of this bleeding, okay, in the gray matter and then the subarachnoid space, edema of the white matter is more likely to occur. So remember, class, if there is injury, the inflammatory processes would set in. And part of the inflammatory processes is that there will be edema because of the influx of inflammatory substances by our immune system. Because of this edema, another side effect that may occur is the impairment in your microcirculation. And with that impairment in your microcirculation, your body will be triggered to release your norepinephrine, your serotonin, your dopamine, and then your histamine. So recall that these are your neurotransmitters. Because of the release of these neurotransmitters, you will have vasospasm. Okay, and okay, other than that, no, because of vasospasm, it decreases also the microcirculation. In other words, aggravating the condition of the patient. Now, because of the decrease in blood flow related to edema, and now because of the decrease in microcirculation because of vasospasm, there is surely a decrease in perfusion and oxygenation of the affected area. Now, with the decrease in perfusion and oxygenation towards that affected area, obviously ischemia would result. If ischemia would not be managed, that would result to tissue necrosis. And this time, we are affecting both your gray matter and your white matter. Okay? And then, because of the prolonged ischemia, there will be loss of function of the nerves. Okay? That's why you're having this problem of loss of motor and or sensory function in a patient with spinal cord injury. Now, there are different classifications of your spinal cord injury. One would be a complete cord injury, and then another one is an incomplete cord injury. Obviously, class, no, as the term would imply, okay, complete cord injury meaning the entire cord is compressed. In an incomplete cord injury, there are still parts of the cord which is still functional. So, for us to understand further a complete cord injury and then an incomplete cord injury, let us try to look at this illustration. As you can see on the left side of the screen, a patient with complete spinal cord injury, okay, would have problems in both sensory and motors from the area or from the site of injury going towards downwards. Okay, going downwards. So if you would look at this example, okay, there is a spinal cord injury which is from the waist level. Okay, so since it's from the waist level, you would suspect that this may be a lumbar injury. Maybe, let's say, for example, an L4 or L5 injury. If the injury is not yet, okay, if this type of injury is not cured, okay, the prognosis of your patient will be poor. Okay, if you would look at this one, okay, probably the injury for this type of patient is involving the cervical area. Okay, but the patient would manifest with tetraplegia and then your quadriplegia. Okay, so there is complete loss of control among the parts innervated by that spine. If I would look at the incomplete spinal cord injury, if you would look at this, if this is an incomplete spinal cord injury in the lumbar region, okay, you'd be interested to know that not all parts of the body are losing motors and are losing sensation. Okay, there are manifestations like this wherein, some patients would feel weakness, okay, some patients would feel numbness on this side of the body, okay, but then he can still wiggle the other side. Okay, so what we are looking into is an incomplete spinal cord injury. So there may be tetraplegia or quadriplegia in an incomplete spinal cord injury, but the sensory muscles or the sensory function, may still be intact. Now, as I've said, complete cord injury would entail complete transection of the motor and sensory pathways, and the loss of function is below the level of injury. Okay, so this is the basic dictum in your spinal cord injury. The loss of function is always below this level of injury. For these kinds of patient with complete cord injury, you would of course expect total loss of motor and sensory function. and that would be below the level of injury. So there is no movement, there is no sharp or dull sensation. So how do we test for sharp or dull sensation? We usually use your pins, okay, and then your pins and paper clips. Okay, so if your patient is unable to identify between the sharp edge of the paper clip or the pins, so meaning your patient is at high risk of having complete cord injury. And then they are unable to do your hot or cold sensation, so they are unable to identify that. Okay, they don't have sense of vibration. They also cannot feel whether it is a deep or light palpation, and then they are unaware of the position of the arms or the legs. So without them looking at it, they are not sure whether you are lifting your hands, okay, whether you are lifting the legs. Okay, so if it is a cervical complete cord injury, they will not be aware of the sense of position of the arms and the legs. If it is a lumbar or thoracic cord injury, so lower complete cord injury, you would expect that they don't have a sense of position of the legs. Okay, so remember that the sense of position of both the arms and the legs is what we refer to as your proprioception. So again, when I talk about a complete spinal cord injury, this is a type wherein the patient will develop complete, okay, the keyword is complete motor and sensory loss below the level of the lesion with the return of your bulbocavernosus reflex. So when I talk about bulbocavernosus reflex, you might be thinking of the penis, okay, because your cavernosus is part of your penis. Now class, when I talk about your bulbocavernosus reflex, this is a reflex which is spine mediated and would involve the level of S2 and S4. Okay, once your bulbocavernosus reflex is back, that would mean that the patient is not already, okay, the patient is not on spinal shock already. Okay, because your bulbocavernosus reflex is one of the first reflexes that would return after a spinal shock. So in case if you're wondering of what a spinal shock is, that will be discussed in a succeeding topic. Okay, so again, when I talk about bulbocavernosus reflex, it is a reflex that indicates spinal shock. So once it is negative or once it is absent or once it has returned already, that would indicate that the patient is not already on spinal shock. Once the bulbocavernosus reflex is still present, that would indicate that the spinal cord severance, okay, is due to spinal shock. So how do we test for this? When I talk about bulbocavernosus reflex, it is talking about the internal and external anal sphincter contraction. That would be in response to the squeezing of your glans penis or clitoris. Okay, or if not, that would be tugging on or pulling on an indwelling catheter. So this reflex class would indicate, okay, if this reflex is active, there will be contraction of your anal sphincter, internal and external anal sphincter. However, literatures would say that this is tested meaning electrophysiologically, which means that a substance, no, manometer is inserted through the anus of the patient to monitor if there will be contractions once you are holding on to the glans penis of your patient or clitoris. Okay, but usually this assessment is done by the physician. So it has some neurologic implications. Again, as I have mentioned, once the bulbocavernosus reflex is back, it would mean that the patient is off already from spinal shock. Okay, so this one is an example of CT scan and MRI images. So this is an MRI image on your right that would indicate a patient with spinal cord injury. So of course, we are looking into the signs and symptoms of the patient. But if you would look at this imaging study, so you can see the degree of injury here and the degree of compression on this part. Okay, which would result to spinal cord injury. Next, you have your incomplete spinal cord injury. So as the term implies, no, it's a partially interrupted with variable loss of function below the level of injury. So it would depend on the part of the spinal cord that is injured. Okay, that the manifestation of injury, I mean, would depend on the spinal cord injured. So it still involves your motor and sensory nerve pathways. Some function below the level of the injury are still preserved. Okay, so we have first the term spinal shock. So class, when I say spinal shock, no, this is the reason why the extent of injury is not fully known until 6 to 8 weeks after injury. Why? There is a condition that we refer to as spinal shock. Your spinal shock class may actually last up to 1 to 3 months. And during the spinal shock, the exact site of the injury cannot be identified because in spinal shock, there is edema formation, there is some bleeding, okay, there are swelling and fluid masses that would mask the true nature of the underlying injury. Okay, so it may extend up to 2 cord segments on either side of the injury. So for that reason, we could not immediately determine, oh, is this an anterior cord injury? Is this a posterior cord injury? Okay, or is this a Brown-Séquard injury until the spinal shock is resolved. So for that reason, okay, I could not determine the extent of full injury until it is 6 to 8 weeks after the injury. So it is not easy to determine the degree of permanent impairment that your patient would have. Again, because of the spinal shock. And when I say spinal shock, this would involve swelling and fluid masses that mask the true nature of your underlying injury. So earlier, we were talking about bulbocavernosus reflex. So class, I said that once the bulbocavernosus reflex is present, that would mean that the spinal shock is already resolved. Okay, so meaning we can see already the true extent of injury of the patient. It is possible that my patient may be having severe signs and symptoms, okay, within a week after the spinal cord injury, but the actual injury may only be minimal. Instead, what is causing that signs and symptoms on the first week of injury is actually the edema or swelling which is present, okay, on the acute phase of illness. Now, so you have the effects of your spinal cord injuries. Particularly, we are talking here about your incomplete cord injury. So if you would look at this, there are three types. No? Earlier, I mentioned about your central cord syndrome, okay, anterior cord, and then I'm talking about your Brown-Séquard. I'll be using this diagram, okay, that I derived from the internet. Okay, credits to the owner of this one. So you have central cord syndrome here, which is illustrated. Now, class, at first, what I would want you to know is that anterior cord would have a poor prognosis compared to that of a central cord injury or syndrome compared to that of the Brown-Séquard injury. Now, the most common cause of your mechanism for anterior cord is flexion or vascular. Clinical manifestations would include the complete loss of motor, pain, and temperature below the injury, but they are able to retain proprioception and vibratory sense. Okay, if you are going to memorize that, you will have hard time, but what you need to memorize is what are the functions of these different areas of your spinal cord. Okay, we'll learn that as we go along. And then for your central cord, that is usually caused by force hyperextension. In a central cord injury, the signs and symptoms will be worse on the upper extremities compared to that of your lower extremities. Okay, as you can see in the illustration here, central cord injury, there is loss of motor function on the upper extremities, whereas there is incomplete loss of motor function in this part of the abdomen. Okay, as mentioned earlier, the prognosis is average. Whereas in your Brown-Séquard injury, okay, it's commonly caused by your penetrating trauma, there will be ipsilateral loss of motor, vibratory sensation, and proprioception. For the pain and temperature sensation, it will be contralateral. Okay, we'll try to understand that as we go along because this is just the big picture of the three injuries. We'll discuss them one by one. Now, let's have a deeper look into your central cord syndrome. So for us to understand the central cord syndrome, you should notice that the central cord that you're referring to is in these areas that are marked red on this diagram. Okay, so in this type of injury, there is preservation of gray matter. Now, in your central cord syndrome, okay, the diagram that I'm showing you would indicate that the mechanism of your central cord is related to force hyperextension. Your handouts may indicate that this is a result of hemorrhage or edema. Now, just think, no? When I say hyperextension, commonly that would be occurring on the neck. Okay? Now, what happens is that, okay, since because of force hyperextension, just think that hemorrhage and edema would occur because of force hyperextension. There will be sensory and motor deficit in this type of cord injury. Now, there is loss of motor and sensory function. Upper extremities will be greatly affected compared to your lower extremities, and then it will be the distal muscles that will be affected compared to your proximal muscles. Okay, so as you can see, the shaded areas here of gray will be the ones that is affected. So as mentioned in your handouts, it would cause by the damage that primarily affects the central part of your spinal cord. So that's obvious since we're talking about central cord syndrome. Okay, one thing that you need to memorize now is central cord is caused by force hyperextension. And when I say hyperextension, connect that already to hemorrhage and edema. Okay, and then connect that to sensory and motor deficit. Since we're talking about central cord, just think that since it's the center, both the sensory and motor deficits would occur. And then, since this commonly involves the neck, because obviously hyperextension would commonly occur in the neck area, meaning your cervical involvement is there, the upper extremities will be highly affected compared to your lower extremities. Let's look into the deficit. Now, let's try to connect still the deficits based on this diagram. Okay, there is spastic paralysis of the upper extremities. So take note, I've said that the gray areas here will be affected. We're referring to the neck as the common site of injury. Hence, the upper extremities are commonly affected. As you can see, okay, the lower extremities is in color white, meaning it's okay. Okay, its function may be okay. As indicated in your handouts, there is some leg movement that is preserved. Okay, there is variable effects on the bowel, bladder, and sexual function. So we are not sure, depending on the degree of the injury, it is possible that the bowel, bladder, and sexual function, such as your sexual or your penile erection, may still be possible. And if recovery would occur, possibly it would start in the legs and then it would progress upward. Okay, so try to remember that for your central cord syndrome. So again, central cord syndrome, force hyperextension. Central cord is damaged. It will be both sensory and motors. However, upper extremities is the one which is affected and not, or rarely, your lower extremities. Let's go to the next one, which is your anterior cord damage. Now, in your anterior cord damage, it says that the damage is on the anterior portion of both the white and the gray matter of the cord. You are looking into this area. Okay? Now, since we are learning that this area is damaged, notice that this part would contain or control your contralateral pain and temperature. And then this part would contain the ipsilateral motor function. Okay? So again, this part here, the lateral corticospinal tract would contain your motor function. Here on this part, on your spinothalamic tract, it would contain your pain and temperature. We are not yet very worried about your fasciculus gracilis and your fasciculus coniatus because they are not yet affected in your anterior cord syndrome. So remember, anterior, meaning it's the front aspect of your anterior cord, or your cord, I mean, which is affected. Now, this is commonly caused anterior. So there is flexion. Okay, just think that anterior is front. And when I flex, for example, picture your knees, or I mean, picture your neck or your chin touching your chest because of severe flexion of your neck. So the tendency is that there will be compression on the anterior part of your spinal cord. So take note of that. Okay, so flexion or vascular. The most common cause is flexion, or the mechanism, I mean, is flexion or vascular. So that may be because of tumors and acute disc herniation. When I say disc herniation, class, okay, it is the disc, no, that's the disc between your vertebrae. Okay, it's the disc between those bones of your spinal cord. Notice that if those discs would go out of its space, the tendency is that the cord, or the spinal column, I mean, will be bent forward. Okay, because the intervertebral disc could be found on the anterior aspect of our spinal cord. Okay, so I hope that you can still connect. Now, so the mechanism is flexion or vascular. Why is that there will be a complete loss of motor and pain? So look at this. Motor function is taken care by this part. So meaning, once this part is affected, there will be loss of motor function. There will be also loss of pain and temperature. And obviously, that would be below the injury because we've been talking about spinal cord injury. It's always below the injury. Okay? So your patient will be able to retain proprioception and then vibratory function because your proprioception and your vibratory function is taken care of here on the posterior aspect of your spinal cord. Okay? Right now, we are not yet very worried of ipsilateral and contralateral because both sides of the spinal cord is affected. Okay, since both sides is affected, we just know that pain temperature is bye-bye, motor function is also bye-bye. Okay? But position is there, vibratory function is there. Meaning, if I am talking about a patient with anterior cord damage and I will lift the hand of my patient, the patient would know that I lifted his hand. Okay? If I will be lifting the legs of the patient will be able to know, or my patient will be able to know that his legs are lifted. So that's your anterior. Let's look at the deficits. Okay, so paralysis below the level of injury. That should be given in your mind already. Because anterior, I said, motors is damaged. Okay, as you can see earlier in central cord syndrome, the motors is already damaged. So much more in anterior because the part which is covered by your central cord injury is also covered in your anterior cord syndrome. Now, there is loss of sensation to temperature and pain, as I have shown in this diagram that the pain and temperature is on the anterior aspect of your spinal cord. Okay, the sensation to touch, position, and vibration would remain intact because I would like to repeat that could be found on the posterior aspect of your spinal cord, which in the case of the anterior cord syndrome is obviously not affected. Okay? So pressure and joint pain sensation may also be preserved. Now, I would want you to picture this diagram in your minds and then think that if the anterior cord is damaged, we say goodbye to your motor functions because that could be found on the middle part of your spinal cord, and we say goodbye to your pain and temperature functions because that could be found on the anterior aspect of your spinal cord. Okay? Now, so again, position and vibration is a go. Okay, it's okay. Let's talk about the next one, which is your Brown-Séquard syndrome. So your Brown-Séquard syndrome is also known as the lateral cord syndrome. So if you would look at it, one side, okay, one side of your spinal cord is affected. Now, it's also referred to as lateral because lateral, you know lateral, it's on the side. Okay, one side is affected. Notice that all of that side of the spinal cord will be affected. Now, I will be worried already of contralateral and ipsilateral here. Okay? Now, look at this. Okay? There will be ipsilateral loss of motors. We know that motors is here. Earlier, you know that motors is here. You know that vibratory sensation and proprioception is also taken care of here. So, there is ipsilateral loss. So, for example, if I am looking at, okay, in this kind of patient, no, okay, let's see, for example, this kind of patient. This patient would be having a left-sided, okay, this is a left-sided Brown-Séquard syndrome. Okay, so why left-sided? Okay, ipsilateral loss of motor, vibratory, and proprioception also on the left side. Okay, whereas for the pain and temperature sensation, that will be lost on the right side. Okay, why? Recall earlier on the diagram that on the anterior spinothalamic tract, which takes charge of your pain and temperature, the effect is contralateral. Meaning, if it is the left side which is affected, the manifestations will be on the right side of the body. Okay, that's your anterior spinothalamic tract. So again, if I have this patient with left-sided Brown-Séquard syndrome, the tendency is that ipsilateral loss of motor, vibratory, and proprioception, okay, meaning left side of the body cannot move, the right side of the body can move. However, it cannot feel pain and temperature. Let's look into the deficits of your Brown-Séquard syndrome and apply, okay, from what your handout tells you compared to this diagram. So as you can see in this diagram, class, no, okay, there is, okay, or in your handouts it would say ipsilateral paralysis on the side below the injury. Okay, ipsilateral, I told you motors is here on this part. So on the same side of the body, there will be an inability to move. Okay, there will be ipsilateral loss of touch, pressure, and vibration. And I told you earlier, touch, vibration, and proprioception is found on the posterior aspect of your cord. And then on the other hand, if this part is damaged, there will be contralateral loss of temperature and pain. Okay? So what I'm pointing out is that if you'll memorize this diagram, if you'll put it into your minds that this is how these spinal cord injury mechanisms would work, you'll be able to discern between these three types of your spinal cord injury. Now, we'll be discussing the injuries to the spinal vertebra that result to spinal cord injury in the succeeding lecture. Once again, thank you very much for your attention.